Greetings, everyone. Please know that we are recording these sessions for later distribution through the Chagas Echo website. We are excited to have you all join us today for the Chagas Echo series. My name is Kato Kawasaki, and I am with the UT Health San Antonio Echo Super Hub. I just have a couple housekeeping announcements before I pass things over to Dr. Stigler-Granados to continue with the introductions. Next slide. Thank you. Here's our agenda for today. We'll start off with some introductions and announcements, then move on to presentations by Dr. Edwards and Ms. Jenks with time for Q&A. During the session, please stay muted unless you are speaking, but we do encourage you to speak. If you've joined by computer, your mute button is on the bottom left of your Zoom controls, or if you're on the phone, just press *6 to unmute. You can also use the reactions menu to raise your hand, or you can use the chat to ask questions. Answer questions and share any perspectives you may have during the session. And finally, please note that no protected health information is allowed in either the chat or our discussions. And next slide, please. And this session is brought to you by the Rockefeller University Clinical Directors Network, Texas State University, San Diego State University, and UT Health San Antonio Echo. And our Echo Hub team members are listed here. And next slide. And the topic of discussion today is congenital and pediatric Chagas disease in the USA. This is session 2 of the 4-part series. And in case you missed our last session, you can visit our website to view the recording. We will drop the link to our Chagas Echo page in the chat momentarily. Also, we will be offering continuing education credits for providers and nurses at 1.5 hours CME credits for each session. Towards the end of the session, we will send out a link to an evaluation survey. Please fill it out to receive free CME or CME credits. And that's it from me. Dr. Stigler-Granados, I'll pass it on to you. And next slide, Karen.
Thank you, Kato. Welcome, everyone. I'm Dr. Paula Stigler-Granados. I am at San Diego State University School of Public Health. I'm also affiliated with Texas State University's School of Health Administration. I'm excited to have you all here today for our ECHO session. And this is, as Kato said, our second out of 4 of this series. And I also wanted to mention, we are offering community health worker CEUs as well for this session if you happen to be signing on as a community health worker. We welcome everyone to participate. We do have quite a few people logged on today. So if you have questions for the speakers, I will help to facilitate that in the chat. We'll have a time for Q&A if you want to unmute yourself to ask questions. Please feel free to do so. We love these sessions to be interactive. So just a little bit more, I wanted to tell you about the Clinical Directors Network, who we have been so lucky to partner with. As we've been doing these ECHO sessions for a few years, we were approached by CDN, and they are funded through the Stavros Niarchos Foundation, Institute for Global Infectious Disease Research. They also with the Rockefeller University Center for Clinical and Translational Science. This is part of a pilot project that they have on Chagas disease as an emerging infectious disease in the USA. You can see the information about the funding, and I also wanted to mention this is also funded in part by a cooperative agreement with the Centers for Disease Control, the Parasitic Division, working with Dr. Sue Montgomery and helping to fund these ECHO sessions. Next slide. Here's a little bit more information about CDN. They're a New York City-based, practice-based research network. They are an AHRQ designated center of excellence for practice-based research and learning. And they're also a network of safety net PBRNs dedicated to improving access to care and clinical outcomes for low-income and medically underserved communities by creating community academic partnerships around research, education, training, and service. Next slide. And without just moving right on to the topic, I'm extremely excited for our 2 speakers today. Dr. Morven Edwards has presented with us in our ECHO sessions in the past. She is an expert here in the field of congenital Chagas in the US. In fact, I think she's written all the top papers on this topic, and I just am delighted to have her with us. She is an attending physician in the Division of Infectious Diseases at Texas Children's Hospital and a professor of pediatrics at Baylor College of Medicine. Her research interests include Group B streptococcal infections in infants, children, and adults, and congenital Chagas disease. So welcome, Dr. Edwards. We're going to also go ahead and My co-facilitator with me, Dr. Zhu, is going to introduce Nancy Jenks as our second speaker, and then we'll roll right into the presentations. Next slide.
We are also excited to welcome Ms. Nancy Jenks. She is a primary care practitioner in internal medicine at Sun River Valley Health. She's a specialist in travel medicine with a particular interest in tropical diseases and immigrant health. She also has been the GeoSentinel Site Director at SRH for over 20 years, tracking infectious diseases in migrant populations. She has published in the peer-reviewed medical literature on the topics that include hepatitis E in travelers, enteric fever, strongyloidiasis in migrants, MRSA and Lyme disease in immigrant populations. So welcome, Ms. Nancy Jenks.
Thank you, Dr. Zhu. And this is a little bit more about me. I've already introduced myself, but for those of you who don't know, I am the PI on our CDC Cooperative Agreement for Chagas disease and a subject matter expert in the topic. I'm happy to be here. So introducing today's conversation, talking about congenital Chagas disease, as an echo session, if for those of you who haven't attended in the past, we like to present it first with information about the topic, and then we talk about actual on-the-ground case studies. And so Dr. Edwards is going to give us a lot of background information on the topic. And then Ms. Jenks is going to talk about her practice in screening pregnant moms. And we should be able to have a pretty good dialogue about how to actually get these screening programs going. So I think without anything else, I'd like to turn it over to Dr. Edwards. While we kind of transition our screen, please be sure to put your information in the chat. Oh, these are just a few reminders. You can click live transcripts. We have the Q&A to ask questions, and then make sure you do your evaluation at the end. All right. I think, Cato, that's all the slides for now. And turn those off. Those will be at the end, and we'll turn it over to Dr. Edwards.
Thank you, Paula. It is a pleasure to be here, and I greatly appreciate the invitation. In looking at the large number of attendees, I see a few familiar but many new faces, and so a particular welcome to those of you who are participating in your first Chagas disease ECHO educational series talk. And without further ado, I'll see if I can start my slides here. Am I good to go?
Yes, you should be able to share screen now. That looks great, Mormon.
Does that look okay?
That looks great.
Aha, there we go.
That's
I'm
it.
advancing. It sounds like you all can see okay?
Yes, it looks great. It's advancing and no problems.
Excellent. So the topics for brief discussion are going to be to get everybody kind of on the same page as to the population at risk for congenital Chagas disease in the United States. And since we're focusing on congenital disease today, the clinical features of congenital Chagas disease in infancy, and then to have a handle upon establishing the diagnosis of congenital disease, and then just a quick comment or two on tips to know which U.S. children are at risk for Chagas disease. So by way of introduction, I now noticed that it's almost a decade since this publication in which Shiba Maimandi was quoted or Shiba Maimanda's study noted that about 20% of the Latin American patients with heart failure in her clinic, which is a clinic of excellence for Chagas disease, can trace their illness to a cause many physicians in the US would not suspect, and that's Chagas disease. So for those of you listening in for the first time today, if you're thinking, I don't know much about this, you are in, I would say, still the majority of people in the United States. But in the past decade, there's been a tremendous increase in awareness and knowledge. And so we no longer think of Chagas disease as exotic anymore. We have a lot of disease in the United States and the challenges to identifying those who have it. So briefly about congenital Chagas disease, that's a picture of Dr. Carlos Chagas in his lab just a little over 100 years ago. And he was the one who identified the pathogen. It's a vector-borne zoonosis with many animal reservoirs, and it's caused by a parasite, Trypanosoma cruzi. The parasite can be transmitted to mothers who have usually chronic but occasionally acute infection during pregnancy. And so the people at risk for Chagas disease are those who currently live or have lived in Mexico, Central, or South America. So for the purposes of our talk of congenital Chagas disease in the US, it is those who have lived in one of these areas where Chagas disease is endemic. The parasite is found only in the Americas, but we'll see shortly that the migration patterns have affected where people with infection currently live, and it's now estimated primarily due to excellent advances in vectorial control in Central and South America, that the number of people with the disease is down to about 6 million. But the issue is that without treatment, this is a lifelong infection, and approximately 1.2 million people who have chronic Chagas disease also have Chagas cardiomyopathy. So just from the beginning, a goal is to back way up to congenital Chagas disease to identify and treat this infection before these infants go on to have lifelong disease and have risk for the heart disease that occurs decades later. So the triatamine bug, or the kissing bug as it's sometimes known, is the vector, and this bug becomes infected after biting an animal or a person who already is infected with T. cruzi. And the mode of transmission is a little bit unusual. You can see in the bottom panel that this is the proboscis, the nose of the parasite is inserting itself into somebody's skin to take a little blood meal. But the person bitten is not inoculated by the bite of the parasite, the kissing bug. The kissing bug defecates after taking a blood meal, and the inoculation occurs when you rub the place where you were bitten and actually insert insect feces into the bite or on a mucous membrane. And so right off the bat, you can see that this is not a very efficient transmission mode. And people who become infected often have chronic and repeated infection to exposure to the triatamine bug. This is a cycle of disease in the parasite on the left and in the humans on the right. And we're going to concentrate on the human stages on the right. Under number 2 there, the form of the parasite that actually penetrates the area of a bite is the trypomastogote. And I'm going to show you a picture of him here, but the trypomastogotes swim along until they find cells into which they can enter. And this is a picture of a trypomastogote in a blood smear. Most of the purplish circles are red blood cells. The large one below the trypomastogote is a white blood cell. And I was shown a live cut of a trypomastogote swimming around in the circulation, and you can see the little tail, the flagella whips around, and these little bugs can swim around very quickly within the bloodstream. And what they do is they find cells into which they can enter and transform into the sexual form of the parasite, the amastogote, that multiplies by binary fission in infected tissues. And what will happen is that it will use up the nutrients within the cell and then transform back into a trypanomastogote at the bottom of the slide and burst out of the cell and enter the bloodstream to find a new cell to infect. So shown here is a picture of all these little dots within the pink at the top part of the slide are amastogotes in infected heart tissue. And the concern is that with time, the trypanomastogotes enter cells and transform back into amastogotes and multiply and find new homes. And so over time, injury occurs to tissues in the body, but the one of particular concern is heart muscle tissue, which can be damaged by the presence of the parasite. This is a slide that just shows as a generality that many states, particularly in the southern part of the US, have either the vector species or both vectors and reservoir species. The very northern cold states are less likely to have the vector or reservoir species. And those exposed to vectors and reservoirs in the US are at risk. So the distribution of places in Central and South America that are endemic for Chagas disease are shown here in red. In its parts of Mexico, especially toward the south, much of Central America, and a good number of locations in South America. And then the infected vectors you may find in your own backyard. I often say that we, as shown here, we have an opossum that had lived under our deck in the back for a good long time. Dogs can be infected, squirrels and skunks. So most people who live in an area that has the vector also has likelihood that there's a number of non-mammalian mammals that can become infected. So with that as introduction, who's at risk for congenital Chagas disease in the US? So the largest group of women with Chagas disease living in the US are immigrants, and we've said people at risk are those who have lived in one of these areas, but now live in the US, and in particular, immigrants from Mexico, El Salvador, Guatemala, and Honduras are at risk. Although there are some parts of South America that pose a great risk, and those include in particular Bolivia. And there's several enclaves of folks in the US from Bolivia. And it's estimated that approximately 300,000 T. cruzi infected people do live in the United States. And that there are approximately among those 43,000 women of childbearing age who not only have chronic Chagas disease that live in the United States, but whose infants are at risk for congenital Chagas disease. And there are two publications, the references are shown there, that have provided estimates. So I've provided the lower estimate from one and the upper estimate from the other to say that we believe that between as few as 22, but as many as over 300 infants with congenital Chagas disease are born every year in the United States. And just to put things in perspective, this is happening year after year after year. And we are not yet routinely identifying these. So there's only been a couple of infants identified who have congenital Chagas disease born in the US. So the reason that there are so many people, these 300,000 people and the 43,000 women, is that the acute disease usually is acquired in the country of origin. And the acute disease at the top of this screen can be totally inapparent with the rubbing of the fecal material from the parasite into the skin. It can be a mild flu-like illness, but many times people don't seek medical care for acute Chagas disease, which then enters a chronic phase that is lifelong if untreated. And so many people will never know that they had chronic Chagas disease. They will remain in what's called the indeterminate form without signs or symptoms for their whole life. And then the remainder, 20 to 40%, will progress over years or often decades to the determinate forms, which most often are the heart disease, Chagas cardiomyopathy, or at times gastrointestinal disease. And this is photos of a child with acute Chagas disease at the site where the bite was rubbed. A painless, firm swelling occurs that's called a chagoma, thought to be that's from parasite penetration. And if it's around the eye, it's called Romagna sign. And this lasts for several weeks, but again, many times it's not in a location on the face, and it again passes unnoticed. So over decades, the cycle that I've discussed with you about how the parasite divides and enters cells, particularly with a tropism for the heart and the GI tract, can cause that chronic inflammation, can cause conduction system abnormalities. And it's thought both due to the parasite's persistence in the tissues and immune mediated responses causing myocardial injury. So the early findings often are abnormalities of the conduction system and left ventricular wall motion abnormalities. But the findings in the heart that can lead to sudden death include cardiac arrhythmias and advanced AV block, and even development as shown here in the photo of an aneurysm of the heart, of the apex of the heart, where at the time of rupture, the first evidence of Chagas disease is that somebody dies from the heart damage. There also is damage to the intramural neurons in the GI tract. And these findings as advanced Chagas disease are less common than those of the heart, but they are nonetheless very debilitating. So on the upper panel, you can see that the motion of this esophagus is adversely affected by the presence of the parasite, and it causes difficulties with contraction of the esophagus, and similarly problems with the parasite in the wall of the intestine, especially the colon, can cause debilitating constipation and impactions and pain. And these effects of chronic disease are more common when the parasite was acquired in parts of South America. And it's thought that this may relate to the difference in the subtypes or genotypes of the parasite that cause disease in acquisition. So since we have fewer patients in the US who acquired their disease, for example, in Argentina and Bolivia, we don't have as many people in the US who have GI disease. Although in talks I've given, I often ask physicians if they have treated it, and I particularly remember in Los Angeles a physician saying that he treated patients who currently had Chagas GI disease. So we do see it in the US. So how can it be acquired? And the bottom line for this few minutes is that we are talking about congenital disease. So I've said that mothers who have Chagas disease, that 43,000 women in the US who are asymptomatically, for the most part, infected from their country of origin can transmit infection to their infants. And it's estimated now by Dr. Karen Byrne and her colleagues that approximately 1/4 of infections now occur through congenital transmission. Other modes are vector-borne, which is unlikely in the US, blood-borne, which is unlikely because our blood supply in the US is screened now, food or waterborne, which is a consequence of a very heavy infestation in an endemic region, and laboratory accidents, which are rare. So mother to infant transmission occurs primarily in the second or third trimester of gestation, but there's little evidence to suggest that it occurs during delivery or postpartum. As I've said, the moms are usually chronically infected and are asymptomatic. And the risk of transmission in the US is estimated to be 1 to 5%. Transmission may be higher in countries where T. cruzi is endemic, and we could talk through a number of scenarios, but it may just relate to higher exposure and higher levels of parasitemia than in non-endemic countries. So that's the population at risk. In a nutshell, the infants born to moms who have lived in endemic areas and now have chronic asymptomatic Chagas disease, but don't know it, are the ones who are at risk. So let's talk about the clinical features of congenital Chagas disease. So we've talked about the number of infected babies that we estimate, but it would be great if I could tell you that these infected babies have this particular finding on physical exam that just says to us, oh, I have congenital Chagas disease. But most infected infants will appear healthy at birth. They have had transmission of the parasite, however, and actually in the first few months of life, they have acute infection, just like the people, the individuals who acquired it directly from the parasite through a bite. And they are equally at risk for developing life-threatening disease later in life. There are, and I always call them the smart little babies, 10 to 40% of infants do have clinical signs of disease at birth. And these findings can include prematurity, hepatosplenomegaly, jaundice, anemia, and thrombocytopenia. But for those of you all who care for newborn infants, none of these is a specific finding for Chagas disease. So for those of us who do care for babies, we need to teach to have a broader suspicion that a baby with one of these signs or more could have Chagas disease and do the testing. So I mentioned there's only been a couple of babies identified in the US, and the first one was reported in 2010. And his mom had moved recently to the US from Bolivia. So this baby was born prematurely by C-section for a different finding clinically, hydrops fetalis. And he was a little tiny baby, 1,800 grams, with APGARs that were reasonable, but it was immediately apparent that he had fluid in his abdomen and pleural fluid and pericardial effusions. And a blood smear in week 2 revealed the trypomastogotes of T. cruzi swimming around in his blood, and the confirmatory testing by PCR was strongly positive, as were antibodies. And this baby being identified received the drug that we'll speak about for 60 days and was cured. So in adapting findings from a number of references of groups of babies with congenital Chagas disease. Approximately 25 to 50% of those who have congenital Chagas disease will have low birth weight. And a similar number will have hepatomegaly or hepatomegaly plus splenomegaly. And as a caregiver for newborns, that's a signal that there is a pathogen that is causing enlargement of the liver and spleen. Petechiae are also found. The platelet count can be low in petechiae. Infants with the finding of the hydrops, the swelling of the body, can have an enlarged heart and heart failure, and other signs there. The babies these babies actually have acute infection, so they can have involvement of the heart with myocarditis or arrhythmias. At times, the parasite can cross the blood-brain barrier, and they can have neurologic signs or anemia. So a broad range of findings. Again, none is diagnostic. So the differential diagnosis is important because congenital Chagas disease findings can mimic congenital infections such as syphilis, cytomegalovirus, and toxoplasmosis, and also for the babies that have this diffuse body swelling, hydrops from parvovirus B19 intrauterine infection. For many years in my career, I worked in a county hospital here in Houston that at its peak was delivering 18,000 infants a year. And I did not know about Chagas at the time, but I saw hundreds of babies with low birth weight, hepatosplenomegaly, and petechiae. And I never once suspected congenital Chagas disease because I didn't know about it. And so to my rue, I'm sure that I could have made the diagnosis, even in this little peak of babies who have the findings on exam, the 10 to 40% who are wearing their infection clinically. If we think of it, we should test for it. And so more recently, I would say in the past decade, if I see a baby where congenital syphilis or CMV or parvo B19 is suspected, and I'm evaluating the baby, I also recommend testing for Chagas disease. So there is a place to make the diagnosis at the time of delivery, but as we'll discuss, the best time is to diagnose the mom before delivery so we can test the baby. And Chagas disease could also mimic non-infectious clinical conditions like congestive heart failure, for example, if a baby had a cardiac arrhythmia, or even respiratory distress syndrome with involvement, which we usually attribute to prematurity. So I'm happy to field any questions, perhaps in the chat if you have them, but let's go on to how to establish the diagnosis. Pregnancy, this is highlighted because pregnancy is the optimal access to identify Chagas disease in at-risk family units because the time of delivery is the most likely time for the mom to have contact with the healthcare system. And many of these moms may not have routine health care. They've migrated from an endemic region. Their risk is enhanced if they've lived in a rural or area or have a mud or thatched roof home in which the parasite, the vector can live. And I'm often asked, but if you really have visited and lived in an endemic region, particularly rurally, you may also be at risk. So these at-risk women should have pregnancy-based screening for T. cruzi IgG. And who should be screened has been determined by these migration flows. And so just focus on the giant arrow on the left. There's been a lot of migration to the US in recent decades, from Mexico, Central America, and parts of South America, as we all know. There are enclaves. For example, there's a large Bolivian population in Catalonia, and there's a large Chagas population in Switzerland. So the US is not the only part of the world affected by migration patterns. And this is just a mud hut showing the kissing bugs there in the chinks, and the arrow on the left is the droppings, which can be infectious. And this just shows the results of a biovigilance program of screening blood supply for a number of years in the US. That sort of, the message of this is that people's county of residence with a positive blood test for Chagas disease has some areas that are particularly full of dots, such as the Los Angeles area and the Washington, D.C. area, and you can pick them out. It just gives an idea of where some people with chronic Chagas disease live. And this nice publication from Dr. Maimandi, in which she screened almost 5,000 Latin American-born residents of Los Angeles County and found an overall prevalence of Chagas disease of 1.24%, especially in those from El Salvador and parts of Mexico, and estimated that as many as 30,000 people or more in Los Angeles County may have Chagas disease. But we don't know what we're not screening for. So the diagnosis must be considered, and screening during pregnancy or at delivery is key to identifying women and infants at risk, but as we know, it's not standard of care. And these moms usually are not of an age yet where they have Chagas cardiomyopathy. So screening can be performed during any trimester, and what one should do is just order a commercially available T-Cruzy IgG by ELISA. It goes to a send-out lab. It's usually back within days. The test currently being used is a good one, and screening can be just included with routine maternal screening for the other potentially transmissible infections like syphilis and CMV, hepatitis that moms are routinely screened for. And it's neither necessary nor appropriate to include IgM in your screening. Pregnancy-based screening is cost savings. A beautiful paper reference there is one of two on the subject, and whether screening is for everybody, universal or targeted, it would be cost savings per birth cohort. So there's no reason that we shouldn't be doing it. And then for evaluation for diagnosis of the baby, we've said that the baby has acute Chagas disease, and so direct detection is diagnostic if positive. If you look at a blood smear and see the trypomastogote, then that's diagnostic. But PCR is most sensitive. It's available through the CDC, and since transmission may result in parasite multiplication in the first weeks of life, a negative test in a positive mom should be repeated at a month of age to be sure that we didn't miss it at delivery. So if you have a mom from an endemic area and she wasn't screened during pregnancy, you can order maternal serology at the time of delivery. And then if infant PCR is negative and maternal serology is positive, you can also make the diagnosis in the infant by being sure that the passively acquired maternal IgG extinguishes by 9 to 12 months of age, which excludes congenital infection. And just briefly, treatment is always indicated for congenital Chagas disease. It's very satisfying. Treatment early kills the parasite and prevents long-term complications. And the cure rates are estimated to exceed 90%, but it's thought that it's pretty much 100%. And then if you identify this woman with congenital disease, treatment is always indicated for the mom too, both for the health of the woman and for the fact that like syphilis, T. cruzi can be transmitted in sequential pregnancies. So finally, I hope by now you have a handle on who's at risk. Those folks who have come to us from countries of endemicity. The clinical features, great if they're present, but only in 10 to 40%. So we need to establish the diagnosis of congenital disease by screening at-risk moms during pregnancy as the most effective method. So which children in the US are at risk? And this is just a couple of slides to end. This study performed in Catalonia screened almost over 34,000 women from endemic countries who had lived in a rural area. And the overall prevalence of maternal Chagas disease was high. It was 2.8%, but it was almost 16% in those from Bolivia and still over 1% in those from El Salvador and Paraguay. And through this screening program, in the bottom, you can see that there are that a lot of screening was done to find the positive women. And among those, congenital Chagas disease was diagnosed in 4.2% or 28 infants. But another interesting aspect of this study is that children born to T. cruzi positive women before the current pregnancy were also screened. They were able to screen 178 children and found that approximately 8% of children from prior pregnancies were diagnosed with Chagas disease. So this is, if you've got an index mom, you've got a person where there's a much higher probability than the general population that you may find other positives. And the important thing here is that these children identified ranged from 3 to 18 years of age. And although treatment is most effective, the closer it's administered to the acute infection, cure rates in young children are also pretty high. And so if one can identify other positives and treat them, you get a lot of bang for your buck. This is a place where we should also be screening. So just to summarize, if you identify an index case in a mom, other siblings should also undergo screening. So among family members, we've already said other children should be screened, but that mom now living in the US may also have acquired infection from her mom. So you should also test the infant's maternal grandmother, and the mother's other siblings, because if your index mom acquired infection from her mom, then her siblings may also be affected. So what you have is kind of a family tree of people at higher risk when you identify someone during pregnancy. So just to close, the CDC has wonderful resources available, and one of them is this fact sheet, Protect Your Baby from Chagas Disease. And I've shown some other printable resources there. For example, what happens to blood donors who test positive?
Anyone go out?
And then finally, you can get a poster through the CDC that you can display in your clinic so that people can learn in English on one side and Spanish on the other about Chagas disease. And just in closing, I would like to thank Sue Montgomery from the CDC's parasitic branch, both for providing some of the slides in my talk and also for over a good number of years now, her example to me as a mentor and teacher. And with that, I will end and ask for any comments. These are some references you may want to gather up if you're interested in screening. Thank you.
Thank you, Dr. Edwards. We do have a couple of questions in the chat. We have a few minutes before Nancy comes on. So one question we have is, what are the main barriers to seeing Chagas disease screening become common clinical practice? Do you think, in your opinion, it's like policy? Is it cost? What do you think?
Well, in my experience, speaking both with groups of pediatricians and obstetric and gynecology physicians, the first question out of everybody's mouth is, who is going to pay for this? The cost estimate for the screening test is not exorbitant medically, but one estimate that I had was $55 from my own center. I understand that a little bit more recent one is more in the range of $125. But ideally, T-Cruzy IgG should be added to the bundle that women are charged for a pregnancy delivery. And it should be incorporated by states into the acceptable screening test. For example, the Texas state law says that screening should include, but is not limited to, those we test for, like syphilis, hepatitis B, CMV, etc., HIV. So it would take going to the legislature with data and saying this test needs to be added at no additional charge to the bundle, because if it's bundled into the whole cost, it shouldn't be too much. I understand that, for example, in New York, screening may be performed in some situations without any charge to the mom. That would be even better. But I have seen a good number of obstetricians just stand up and say, who's going to pay for this? And then even if it were incorporated and accepted, it would only be done if it were on the electronic medical record in a convenient way for the obstetrician to just click it as send this. Does that help?
Yeah, and I think Nancy's going to be talking a little bit about that as well. So cost is prohibitive sometimes, as well as just the fact that a lot of maybe practitioners aren't even really aware of the disease itself. And so that could be some of those barriers. We also have quite a few other questions coming in the chat, but I do notice we have a hand raised from Cordella. I don't know if you want to unmute yourself and ask your question.
Hi, thank you so much, and thank you for that very informative presentation. Mine is more of a comment, and it follows on your response to the previous question. And is this information available at WIC clinics? And should the screening also be included in Well Women's visit, as it would possibly allow for treatment before the woman gets pregnant?
Those are both great questions. I don't think it's incorporated in WIC clinics. I don't think it's actually incorporated anywhere that I know of, but that would be a good set of clinics in which it could be incorporated for the reason that I would think that you all have a high risk population for Chagas disease, at least in a number of your clinic sites. And it might be easier to introduce it as routine into WIC clinics than in some other settings. The answer to your second question is that that treatment is not advised during pregnancy. There are not any definite risks of the treatment drug benzonidazole, the most common one, to the infant, but it's advised to withhold treatment for the mom until after delivery and after she's completed breastfeeding. Again, there's no evidence that it actually crosses to the infant through breast milk, but it's still advised to withhold it until after that.
Thank you, Dr. Edwards. And again, I want to give Nancy plenty of time for her discussion. And Dr. Edwards, if you and I can be active over in the chat, we have quite a few really good questions coming in. And then also I wanted to thank Maya Carrion for sharing some resources that BU, who's also another cooperative agreement partnership with the CDC, has also shared in the chat. So if you're not looking at the chat, go ahead and sign on to that and take a look at, and Dr. Edwards and I will work on some of these questions. And meanwhile, this is really good discussion, and I think Nancy is going to provide some really good insight into how she has set up an amazing screening effort right now, and talk about the challenges and the successes and what's to come with the program. So I'm going to go ahead and turn it over to Nancy if you're ready, and we're going to advance the slides for her.
Thank you, Paula. You can go back to the first slide, actually. It's really a pleasure to be here today, and I want to thank the organizers for inviting us to speak about our very new initiative to screen for Chagas disease, very much a work in progress. But I also want to take the opportunity to thank Dr. Edwards, not only for today's very comprehensive overview of congenital Chagas, but also her incredible dedication over many years to research publications and also educational endeavors in order for us to better understand Chagas disease. She's really made a tremendous contribution to bringing this neglected tropical disease into the light and beginning to guide clinicians in organizing best practices. I've entitled this presentation Looking for Chagas because Chagas is undoubtedly, as we've discussed, a disease that we need to look for. For a healthcare provider here in the United States, Chagas does not present itself clinically, and it's largely a chronic infectious disease. And much like other chronic diseases, such as hypertension, it can be a silent killer. Therefore, screening appropriately and treating can be life-saving. If you can go to the next slide. So for the next few minutes, I will briefly describe our federally qualified health center, our FQHC in New York State, and kind of tell you the story of how we first became interested in our latest endeavor to screen and treat Chagas disease. And then I'll discuss our process in organizing our pilot project. And again, it's definitely a work in progress. We've just begun. And then we'll go through a couple of cases. If you can go to the next slide. So Sun River Health is a FQHC, a health center in New York State. Our organization was founded by 4 very dedicated, insightful women in the 1970s in Peekskill, New York. And as the needs for healthcare homes were identified in surrounding locations, our center expanded. In fact, this slide is already outdated. We now have 51 sites up and down the Hudson Valley in New York City and Long Island. And we serve over 250,000 patients. And some of our latest data that we were looking at recently show that about 41% of our patients were born outside of the United States. So we've been very much, as I'm sure you all are, very tuned in to where our patients originate from. We've always strived for cultural competence. And over the years, we've also become more and more aware of global health issues and epidemiology of diseases that could certainly affect our patients in certain populations. So how did this endeavor to screen for Chagas disease come to us? If you can go to the next slide. I'm going to give a little bit of a history. In 1991, the International Society of Travel Medicine, ISTM, was founded creating a specialty concerned with disease risk for travelers and helping to mitigate those risks. And then in 1995, out of ISTM, in collaboration with CDC, the GeoSentinel network was founded. And this comprised of initially a small number of practices who tracked post-travel infectious diseases. And a few of these practices were also seeing migrants and immigrants, and they were included in the network. So through my involvement with ISTM, the GeoSentinel leadership understood that our patient population included a large number of immigrants, and we were asked to join the network in 2001. And since then, we've been collecting data of infectious diseases in our populations of migrants and immigrants. And if you can go to the next slide. There have been hundreds of publications over the years from GeoSentinel data, including in the area of migrant, immigrant, and refugee health. And here's an example of a recent journal article, which actually includes data on Chagas disease in these populations, authored by some of our GeoSentinel colleagues. Next slide. But what I know is, when I go back after more than 20 years now of being part of GeoSentinel and tracking infectious diseases in our migrants, and we have contributed a lot of data to this vast data set of infectious diseases. But if you look, we only had one case in all this time of Chagas disease. And this one case was actually one of our patients, a Mexican immigrant who donated blood and then was formed of infection. So he came to us for treatment. We were his healthcare provider, and he at that time had significant heart disease. So just to say, at our annual GeoSentinel meetings over the years, and I think this is really important when we talk about what networking in general, but many of my colleagues have asked, why don't you start screening for Chagas at your FQHC? And as already alluded to, one of our main barriers centered around cost of screening. So, but by connecting and networking with some of the true experts in the area of infectious diseases, we really were encouraged to begin this screening. So we put together a team who were interested and invested in the endeavor, and we opted to design a pilot project for screening. And we framed this as a quality improvement project. And in this respect, it wasn't a research project. There was no need for our IRBs. It was a vested group of individuals who really understood the importance of looking for Chagas. Exactly a year ago, in January of last year, we presented our quality improvement project to our Quality Improvement Council with the rationale, and they approved our endeavor. You can go to the next slide. So now we had to organize our pilot, and we wanted to choose a site and a cohort of patients to begin with. We obviously wanted to put together our team and train and educate our staff, many of whom had never heard the word Chagas. And then we really wanted also to work with informatics to try to create, as Dr. Edwards was talking about, templates for our EMR to ease providers into knowing how and when to screen for this. Next slide. So we opted to start small in number, and the process, we're also busy. Every practice is busy, and we really did not want to overwhelm ourselves saying, starting tomorrow, we're going to screen for anyone who's from an endemic area for Chagas disease. So we really wanted to design this with a small cohort of patients. And obviously we wanted it to be the right population, so patients from Chagas endemic areas. And again, with being enlightened by our colleagues, realizing that obstetric patients would be a captured audience in the sense that they do come in regularly for care when they're pregnant. And in New York State, they have health insurance, and there's a much greater ability to track these patients because they are coming in multiple times. We always kept in mind, or we have kept in mind really what our mission is. And as Dr. Edwards spoke about, I think the beauty of screening and looking at the young moms is that if we are picking up congenital Chagas when the babies are born, then the treatment is so successful. Next slide, please. So what I did, and this was again a year ago, I went to our informatics system and I chose we chose a practice, an obstetric practice out on Long Island where we had about 100 obstetric patients. And fortunately, for many years, our EMR, we always asked as structured data, where are you from and how long have you been here? So it was very easy to pull up the countries of origin of these 100 obstetric patients. And as you can see from this, we had at that time almost 80% of people who either El Salvador or Honduras, both highly endemic for Chagas disease. Next slide. So we put our team together, and I think that without a doubt, we really did need guidance. We were all new at this. We'd never done this before. And, another big shout out to Dr. Sue Montgomery, who's from CDC's Division of Parasitic Diseases and Malaria, who's been so really supportive of our endeavor, and also Dr. Christina Coyle, who's an infectious disease specialist in the Bronx, and really a renowned expert in the area of parasitology. And she also happens to be a GeoSentinel colleague of mine, and I've known her for quite a while. So being able for our team to meet regularly also with them, and they've been so generous with their time and energy in helping us set this project up. Next slide, please. So, we found their guidance was so important, along with other people that were helping us in this area. And then, of course, we had to train and educate much of our staff. And the training went beyond just learning what Chagas was, but really looking at how were we going to test for it? What were we going to do if serology was positive, in the way of how are we actually going to be sending the blood up to our Department of Health lab, and we'll talk about that in a minute. We had to create the protocols for screening and tracking, and again, working with our informatics to start, and we're just beginning this process of really setting up templates for both screening and also treatment and tracking. And then the last point here is an important one that, again, Dr. Edwards talked about, that organizing really a system to bring in family members. So, and when we look at some of the cases, some of the women that we have seen have had other pregnancies, so bringing in the siblings after the baby is born. Next slide. So we started by screening pregnant women at our Brentwood site back in the summer. Next slide. And now I'm going to go through just 2 case presentations, so you'll get an idea of how we put all this together. Next slide. The first case, I'm actually going to flip back to March of 2016, when we first met this patient from Honduras who came to our health center for prenatal care. She had already a young child, and she'd been in the States for about 10 months. Next slide. As you can see here, these are just snippets from our EMR, from our electronic medical record. We're getting, obviously, a family history. Hers didn't have too much to add. And social history, as I mentioned, where were you born and how long have you been here? Next slide. So this is, again, in April of 2016, and this is one of the panels of prenatal bloods that were done at that time. Next slide. So she had a normal delivery, a nice, healthy baby with good APGARs. Unfortunately, in 2020, she was infected with COVID. And then in March 2022, she landed at the ER with numbness in her face and extremities, some chest pain and palpitations. Basically, she had a negative workup at the ER, but she was referred to cardiology. And we'll come back to that in a moment, where she had a normal EKG and echo, and her neuroscience and symptoms eventually resolved. Next slide. So then in February of last year, she returned to our health center for prenatal care. Next slide. And we, as part of our new initiative, we screened her for T-Cruzi antibodies, and that was sent to our commercial lab. Next slide. So you can see here the lab order. And this was, yeah, and this was actually, I'm not even sure if it was July. It may have been a little bit after July when this lab was done. Next slide. So the commercial serology was sent, no, it was in July, and then it came back positive. So then 2 tubes of both whole blood and serum were sent to our New York State Department of Health lab, Wadsworth, and for confirmation. And then it was sent on also to CDC. Our state lab does the ELISA tests, the Wiener and hemogen tests. And if they're not discordant, then usually that's it. But in some cases it is sent on to CDC, where in this case, the test of the immunoblot test was done also positive. Next slide. So by the time all of this came together, she'd already had her baby, but we went back then and started honing in on some of the pertinent questions in the EMR. Not only, and a lot of our, we have developed a template now for this, but many of our medical assistants and nurses are now tuned in to not just ask what country you are from, but a little bit more specifics. As in this case, she lived in a house with a thatched roof, lots of holes and cracks in the house. I know on my computer, I have a picture of a kissing bug. So you can say, do you recognize this bug? And you can really dig in a little bit more. Next slide. And again, this goes through some of the questions that we asked her. She didn't recall any family members with Chagas disease or heart disease. All of her different labs that were done are listed on the bottom. Next slide. So she delivered a healthy baby girl in September. And what was interesting here is she was called back by the same cardiologist that had seen her post-ER visit. And she had seen him a couple of times even before any Chagas disease had been diagnosed. Next slide. As I mentioned, normal EKG. Next slide. And I think the point, this is a note from her cardiologist of, basically saying she's now a mother of a 3-month-old and everything's great, and heart-wise she's doing well. But if you look at past medical history, nowhere in the report that I saw from this cardiologist did I see the word Chagas disease. And I think, it just speaks to the importance of, once we start screening for Chagas and getting tuned into Chagas, we need to also connect with our primary care cardiologists in the area so that there's good communication. We all know that specialty care sometimes is not connected well with primary care, and we need to make that connection, particularly in these cases. Next slide. So she's going to be following up with a cardiologist. Okay, we can go to the next slide. So this is our second case. This was a patient from El Salvador who arrived in the States in 2015. She came in just for a routine checkup. And she did mention, if you go back to that checkup in 2015, she did have a family history of cardiac disease, her dad and her uncle, she mentioned. And then in 2017, we followed her for prenatal care and she delivered a healthy baby. In 2020, another prenatal visit. She also was infected, unfortunately, with COVID-19 in 2020. And in August 2020, delivered a healthy baby. Next slide. So she came to us again in November of 2022 with a positive pregnancy test. and to begin prenatal care. And she was tested, she was screened for T. cruzi. Next slide. This is the commercial test that came back reactive. Okay. And this was the confirmatory or the test that was sent up to our New York State lab at Wadsworth. And again, both of the ELISA tests were positive, were reactive. So she was diagnosed with Chagas. Next slide. Now she's one who now has delivered. She's not breastfeeding, and we're just beginning the process of treatment, which is we have two wonderful infectious disease doctors who are our go-to people for treatment, and we're with the help again of our experts such as Dr. Coyle, we're putting together for our EMR templates for treatment for benznidazole, how often to bring them in, monitoring side effects and so forth. Next slide. And, you know, cost we've talked about, and cost is an issue. The prenatal tests the serologies can be covered, but again, when we then need to get other studies such as echocardiograms, who's going to pay for that? And these are always issues that are barriers in terms of the care. Next slide. Again, another piece of our EMR. And when we went back and started filling in the questions, not only do we know a little bit more about her home in El Salvador, the bathroom was outside, she did recognize the kissing bug. And in fact, she also realized that, yes, her father had Chagas disease, and so did her uncle. So these were questions that were not asked initially in previous pregnancies that now we could hone in on these and fill in some of her family history, which was really important. Next slide. So just to wrap up, again, you know, we're just in the beginning of this process, so we certainly don't have all the answers. We're kind of making our way with the help of others around us and experts around us, but we really felt like our take-home points is starting small has been really important for us in terms of kind of organizing the process. And the cost issue is always a big issue. And of course, prenatal, for us in New York State, women who are pregnant and pediatric patients have the benefit of insurance. And we've certainly taken advantage of the resource networks to support what we're doing. As I said, we meet monthly, both internally and also Drs. Coyle and Dr. Montgomery often will be helping us through each of our steps. And then the final take-home point is we really need to look for this disease because it's not just going to show up at our doorstep. And we just need to do the appropriate screening because without a doubt, especially in the obstetric population, when these little babies are born, and if they are PCR positive, if we diagnose Chagas disease, then they have close to 100% chance of cure and not going on to having this potentially in what 20 to 30% of people that will go on to have significant heart disease as adults. And I think that's the last slide. Maybe you can go forward one more. Yeah, that's it. So thank you very much for your attention. I hope this was helpful, and maybe a year from now we can come back with more experience because again, we're just beginning to our very exciting, I think, initiative. So thank you.
Thank you so much, Nancy. This was really informative. I am kind of wondering if anyone else here in the session has had any experiences with screening in their clinics and would want to share any of their experiences. I know I see a few of you I know who do have some experience, and I know I just put you on the spot. But I really love the way, Nancy, you put this as a quality improvement project. It's something that I think more places, especially those that are seeing patients that are from the endemic regions, would have a really great opportunity to implement this at a small scale to start, just to see, you know, if there's a need in that community, which I'm fairly certain there would be. Would anybody like to share any of their experiences? And you can also put it in the chat. Sometimes if people don't want to talk, that's a great way to do it. And I also wanted to mention too, we do like these sessions to be interactive. Sometimes it's a little quiet when we have so many participants, but we do have a couple of poll questions. I'm going to see, Dr. Edwards, we were supposed to launch some during your session and we forgot. I'm so sorry. But we could see if we are able to launch a couple of those poll questions just to kind of gauge what people took away from the sessions. Let me see. Here we go.
I think it is I who should apologize, Paula. I'm sorry.
It's okay. We get excited about the conversation and sometimes we forget. So here's a question. If you all could just quickly pop an answer into this. The risk of congenital transmission from a mother with chronic Chagas disease to her infant is 1 to 10%, 11 to 25, 26 to 50, or greater than 50. And it looks like a lot of responses happening right now. The majority said 1 to 10%. Dr. Edwards, is that correct?
That is correct.
And I think for a lot of the reasons that you mentioned, not every mom will pass this on to their infant. But I think also we don't know a whole lot about it as well. And I think with more screening, we might also have more information about congenital Chagas. All right. Next question. Let's see. What percent of infants with congenital Chagas diseases are symptomatic at birth? Less than 10%, 10 to 40, 41 to 75, or greater than 76? And while you all are answering, Andre in the chat posted a question about experience with rapid tests for screening. So some of those lateral flow tests, does anyone have any experience with using those? I know we've got the NBIOS test that is FDA approved in the US. And I'm wondering, has anybody thought about that as a possibility of screening at their clinic? I know I work with some people who have been talking about using these at community events, as long as the people that are screened are able to obviously get confirmatory testing and go through other tests linked to that. Anybody have any experience with that they want to mention? And Dr. Edwards' response to the question, less than 10% or 10 to 40? We kind of have a split here.
We kind of do, and it's 10 to 40. So it's those smart little babies who are displaying their clinical findings by exam, but remember that none of them is diagnostic in itself of Chagas disease. It's like they're raising a hand and saying, please test me for congenital infections.
Great, thank you. All right, we have another question. Cure rates for congenital Chagas disease exceed 90% when instituted in the first month of life. True or false? We also have a comment in the chat, and from Claudia saying she's seeing presentation on Chagas for the second time. This is very informative. She does have children that are coming from Central America and Mexico, refugee children in care of the state. So hopefully, Claudia, this is good information. And obviously you will have our contact information if you would like further follow-up with experts on this topic. So 98% said true. Is that correct, Dr.?
That definitely is true, and thankfully so, which just emphasizes, especially what Nancy has brought out, the importance of actually instituting processes to identify both the moms and their babies, because we can treat and cure the babies. Thanks, Nancy, for your great presentation.
Thank you. And Dr. Mandy, I see you have your hand raised. We'd love to hear from you.
Yeah, I just wanted to make a couple of comments that you had asked about before, Paula, in terms of our experiences. We have added the screening test to our neonatal panel, and our challenge became that over the course of maybe 5 years that we tested, the positive rate was so incredibly low. I think we had one baby in 5 years that the organization dropped the screening. The OBGYN department felt it wasn't warranted. So that is that is a problem that we will face, because transmission rates can be very, very low. And I think someone else mentioned here in terms of the in-bios testing. The first batch, when it was first developed, we had a lot of false positive tests. So we stopped using the in-bios, but the newer batch, Norm Beatty, who's in Florida, University of Florida, and I think Maja just commented on that also. They've been using it as part of their screening test. So they do that first, the rapid test. And then if positive, they get a confirmatory, they do confirmatory testing. And if that's positive, then they go ahead and treat. I don't have documented evidence in terms of the specificity and sensitivity from a firsthand experience myself, but Dr. Beatty has been pleased with the results. That's it.
Thanks, Dr. Mandy. And yeah, it's a conversation that I've been having around the table about these rapid diagnostics, and also with the DTUs of the tests being, effective on Central America and Mexico, being more effective in South America. And we're still learning and understanding, and false positives are never fun to deal with. And so making sure we have more confidence in those rapid tests is something that we're talking a lot about right now. I'm thinking a lot about. I think obviously it's a great diagnostic tool if they work. And so I think that's the challenge, is to make sure that they're working and giving the right information. And I do think we have just a couple more poll questions. And then also, as you all have more questions you're thinking about for the speakers, please feel free to put them in the chat. So one positive serology for T. cruzi from a commercial lab is conclusive to diagnose Chagas disease. True or false? One positive serology for T. cruzi from a commercial lab. What do you all think? All right. I think I'm just going to go ahead and end that. I think almost everybody said false. We did have a few people that said true. And Nancy or Morven, you want to chime in on why that's not true, why it's false?
Well, it's false because that's what I was taught by the experts.
Yeah.
No, I assume that you want two serologies to give a definitive diagnosis, and sometimes those two are discordant, and then you need the third immunoblot or whatever's being done at the CDC. Is that correct, Dr. Edwards?
Yes, that's correct. I was just trying to think of a way to express it. The screening test is an ELISA, and so it can be positive barely, and if it's truly a positive, it will be higher end positive repeatedly. Does that make sense at all?
It does. And I think there's also, and this could be a whole other topic of conversation, there's a lot of issues with some of the diagnostic tests and just how they work. And I feel like having that second serology and confirmatory testing is extremely important because there's also cross-reactivity and other things that can happen. And so this is why we always recommend at least 2 commercial lab tests and then a confirmatory test from the CDC as needed. So great responses there. Next question. I think we just have a few more. All right, so Chagas disease during pregnancy, which statement is true? Just mark 1. It's not necessary to test pregnant women for Chagas disease since it cannot be treated during pregnancy. A normal ECG can rule out Chagas as a diagnosis. And pregnant women who are at risk for Chagas can benefit from screening. All right, and I feel like we got almost everybody answering there. And so almost everybody said pregnant women who are at risk for Chagas can benefit from screening, which is correct. It's not necessary to test pregnant women for Chagas disease since it can't be treated during pregnancy. I think that's a false statement because we know that if you can test them and they do test positive, then we know how to subsequently test the newborns as well. And then a normal ECG can rule out Chagas as a diagnosis, and that's incorrect because Chagas disease chronic does not always present and whenever it is still in the indeterminate form. So great job. All right, we have one more question, is that correct? All right, testing during pregnancy for Chagas must be done during the 3rd trimester, true or false? All right, we said almost everybody said false, a couple of trues. Would Dr. Edwards or Ms. Jenks, would you like to elaborate on why that's false?
Well, testing can be actually done in any trimester because these women have chronic disease, and it's just a matter of convenience at what point in pregnancy the testing is done. The main reason that testing in pregnancy should be a part of the panel is that then the woman is identified as at risk for having an infected infant, and we will have her back to deliver the infant. So we'll have mom and baby together at the time of pregnancy, and we can counsel the mom and treat the baby. So it's mainly to get them into our sphere of influence so we can help at delivery.
Great, thank you.
Nancy, something to add?
Oh, go ahead.
No, that's, I agree with you 100%.
We have one last question in the chat before we close out. Could you elaborate on whether it would be difficult or not to incorporate the screening and treatment forms from the Quality Improvement Project into EMR systems? They would be great tools to streamline at the healthcare level to help healthcare providers. I don't know if Nancy, you want to, whether it would be difficult or not to incorporate the screening and treatment forms into the EMR systems. What's your experience with that?
No, I think having that done is hugely helpful because, and we know that from many different things we screen for, whatever prompts that we can have that will help guide us in terms of best practices. And I think that's truly the beauty of EMRs.
Did you have any difficulties with implementing that, or what was your biggest challenge?
Well, it's still very much in progress, as you could see from the cases. And that would be a question, I think, next year. We'd be probably better in answering it. But, you know, we have templates for so many different things, and they do prove to be very, very helpful in terms of guiding the providers that are seeing the patients.
Great. Thank you so much. I think, Cato, you're going to launch just the last closing slides. I first and foremost wanted to thank everyone for being here. I believe these last slides also have our contact information. We are recording this session, so it will be available to watch again or to share with your colleagues. Also, CDN has graciously been able to provide continuing education, CMEs and CEUs for those of you who would like to watch the recording. So if you do share it with your colleagues, let them know that CME is available. We should have these posted rather soon, maybe in the next week or so or less. And also the CME certificates will be issued within about 3 weeks following this session. If you have any questions, please reach out to chagasus@gmail.com. That actually comes straight to me. So I'd be happy to direct you to any resources that you need. It'll pop right up on my phone and I'm happy to respond. Is there one more slide? Or is that the last one? Just a reminder, this is the evaluation. If you are getting credits, please fill this out in order to get those CME or CNE credits or CEUs. And also, if you're not getting credits, we still appreciate your feedback. We always want to know what you think and what we could do to provide better sessions for you all. And with that, I just want to thank our speakers. It was wonderful to hear your stories and your case presentations. And I hope that this was helpful for everyone. And hopefully there's more screening programs that are being set up as we're speaking, and more awareness is being raised about this very important topic. So thank you all so much. And we're going to go ahead and sign off. If you do have any last questions that you'd like to ask offline, we're going to be here for just a few more minutes. But thank you all. Have a great week. Next session is the first Wednesday of next month. And we are going to be talking about migrant health issues concerning Chagas disease. So it'll be a great session. Stay tuned and we'll send you out more information as well. Thank you so much.